sir.
Good morning. We are going to start this session where, every conference that we see, and then look at a new technology. And today we are going to talk about, we have an eminent panel of speakers. And every speaker is going to tell their own experiences in what they feel, and then the message has to be conveyed to the audience.
Is Dr. Athishwar Das here? Dr. Athishwar.
Yeah. So he is going to talk his experience with a triphobic trifocal IOL.
Podium 1. Very good morning. I'm here to share with you my experience with the triphobic trifocal, the new kid on the block. We did a comparative analysis of diffractive trifocals with extended range of vision in our center. It was a 1-year study. So this was the aim of the study, to compare the visual quality and outcomes. We included around 55 patients with 110 eyes. All were operated in a single center by a single surgeon. So these were the lenses which we compared. Physiol trifocal, true trifocal diffractive IOL, the Zeiss 80 Lisa trifocal, and the Acryvision or the triphobic trifocal of Care Group, the EDOF lens of Symphony. And we did also include the toric trifocal in those patients who had high cylinder, more than 1 diopter pre-existing. So all of them underwent uneventful bilateral cataract surgery between August 2021 to 23 year. And we used optical biometry with LensStar. We did a complete preoperative exhaustive evaluation, which I will just highlight due to paucity of time. We did do a complete dry eye evaluation. Those who had moderate to severe dry eye were excluded, and those with high angle kappa measurements in the topographer were also excluded beyond 6 degrees. Anyone with prior refractive surgery were excluded, and also people who had macular pathology or retinal laser were also excluded. So these are the lenses we compared. So the broad base differentiation between the lens here, you can see I like to highlight about triphobic, which had around 92% light transmission, where 50% was distance, around 20% for intermediate, around 30% for near. And it is pupil independent. Same thing with like PanOptics, which has enlightened technology. And these were cast-mounted lenses, the triphobic, so that amount of glare and halos were considerably less. So there are different technology or the commercially available diffractive IOLs. You have the trifocal diffractive apodized lens, which is a Physiol. Then you have that trifocal diffractive non-apodized, which is PanOptics with the enlightened technology. The triphobic has an increased angulation and decreasing height from the center to the periphery in their trifocality. So this gives them better amount of focus and also reduces glare and halos. Since they are cast molded lenses, they have less imperfections, and the defocus curve is also very gratifying. I'll share with you our details, our study. This is the energy scan which they have given to me from the company about the MTF values. So you can see the MTF values is good in near, intermediate, and distance as well. So just a video of this patient who underwent trifocal toric implant. He had a pre-existing diopter of 2.5 cylinder. I always aim for a 5 mm rexis, circular and centered. We do a pre-operative marking, and these patients are always done under topical anesthesia. We ask them to focus on the lights, coaxial lights, and try to center it around the first Purkinje images. I'll just move out for the paucity of time. A routine phacoemulsification, and this was the lens which was implanted. 11 degree was the axis. So you can see it comfortably goes through a 2.2 mm corneal tunnel. Once implanted, we always ask the patient to foveate or fixate to the coaxial light, then center the lens accordingly. This patient was centered at 11-degree axis, and post-operatively, he was 6'6" and 6 unaided. This is another similar patient. Due to paucity of time, I'll skip to the next video. These are the 4 different lenses we compared. This AT LISA tri goes through a 1.8 incision. Smaller, the Physiol, however, required wound-assisted implantation because it was a much larger lens of 6.25 mm optic. The Synergy has a screw-type cartridge, so you can't do it with one hand. You need a bimanual implantation, the Synergy. The Triphobic goes through a butterfly cartridge, which is smooth and easy to deliver. So another small note over angle kappa. We did analyze angle kappa preoperatively with the ocular topographer, and we found that angle kappa doesn't have a great impact in the postoperative visual outcome, unless there is an excessive amount of decentration. Angle kappa, the chord length is between the visual axis and pupillary axis. If the chord length is more than 0.5 or 0.6, we try to exclude them, but only when there is decentration. This is a small slide which I picked from Dr. Uday Devgan on his cataractcoach.com, where he says that the negative aspheric IOLs are more prone for comas if they are decentered mildly. Even a 0.5 mm decentration causes coma. However, the trifocals, I didn't encounter much amount of comas or aberrations post-operatively, because we always centered them, asking the patient to foveate in the coaxial illumination, and we centered them on the first Purkinje images. So this is how we centered. This is the optical axis, and that's the pupil center, and we try to center them according to the pupil center. So in all, 22 males or 44 eyes and 33 females, 66 eyes included in the study. Distance visual acuity was recorded at LCD chart at 3 meters. We also used ETDS chart at 4 meters. Near and intermediate visual acuity is recorded with a column branded chart, and subjective perception of glare and halo were recorded with the images shown. So this was the conversion we used, logMAR to Snellen equality. This was the distance visual acuity tested at 3 meters on an LCD charge and converted to logMAR. Here you can see all the 3 lenses performing extremely well at 1 week, 3 months and 6 months. They all were 6 by 7.5 or 6 parts unaided. So the ETDS chart at 4 meters, we found that initially the patient, because it was not illuminated chart, the ETDRS, so initially they were 6'12" or 6'9" the first week, and slowly they improved with binocular implantation to 6 by 6, end of 6 months and 1 year. This is the colon branded chart which we used for intermediate vision at 63 centimeters. So at 63 and 40 centimeters, again you can see the trifocal lenses were doing well, diffractive trifocal, triphobic doing well for near and intermediate. However, the Symphony wasn't good for intermediate and near vision. However, we had to do a micro monovation of the fellow eye so that binocularly they are able to read N8 or N10. So this is the intermediate chart we use at 100 centimeters. And the intermediate chart, Colin Brander at 100 centimeter, again showed extremely good outcomes with Physiol. It's the diffractive trifocal. Similarly with 8T LISA tri, and triphobic also matched up at the end of 3 months and 6 months. So these are the Bardell images which are given to us by the different companies. Again, I would take this with a pinch of salt because it varies predominantly. I wouldn't go by what is shown here. This is a description about how the focus is there on intermediate and near focus, amount of glare and halos. So this is intermediate vision with the trifocal. As you can see here, AT LISA tri gives the best trifocal clarity with intermediate vision. So post-operatively, we assessed for PCO with retroillumination at 6 months and 1 year, and we found that the hydrophilic lens, the AT LISA tri, had more incidence of PCO, and we had to go for a selective YAG capsulotomy much earlier. So to summarize, accurate preoperative biometry is very essential when you're going with these trifocal implants. Look at angle kappa and the chord length measurements if you have an optical ocular topographer. Go with universal Barrett formula, aim for a central rhexis. The right IOL, I would prefer in a myope with presbyopia, go with a trifocal with hybrid vision, that is a fusion IOL or a EDOF IOL and a trifocal in one eye. Hyperope with presbyopia do very well with trifocal IOLs implanted bilaterally. And very important, complete removal of OVD from behind the IOL to avoid capsular back distension syndrome in these patients, because we would definitely opt for the second fellow eye surgery within 2 to 3 days after surgery. And if there's any refractive surprise, we wouldn't try to go with this fellow eye surgery immediately. To conclude, trifocal IOL provides a good range of vision when implanted binocularly. The subjective photic phenomenon is more with Physiol compared to AT-LISA trifocal, compared to triphobic, and Symphony have the less photic phenomenon. PCO rates, posterior capsular opacification, was much higher with AT-LISA trifocal, 4 out of 22 eyes, due to the hydrophilic nature of the lens, and we plan to do an early YAG capsulotomy, and we did for 3 months and 1 month also. Near and intermediate vision were good with AT-LISA trifocal and triphobic. Symphony implants, however, didn't offer good unaided near vision, and micro monovision was planned for the fellow eye. Thank you for your kind attention.
I think very well captured, Dr. Sridhar. Just a couple of questions. I believe that a surgeon's faith in a lens is, would he do or use that lens for a clear lens extraction in a patient who's probably seeing well for distance and he's looking for near vision. That's my hallmark. What is the lens I would put for a person who comes to me for just a simple refractive correction and he's 50, 54, 55, 56? So in your opinion, would you be putting a trifocal lens?
It's always been it's the holy grail in ophthalmology. We are not able to get the ideal lens which suits everyone. It again depends on his refractive error. Like I said, for a hyperope and who's a presbyope, who's extremely dependent on glasses. For example, he's got plus 2.5 for distance and 2.5 for near. I would definitely aim for a trifocal in him. However, a myope who's like -3 and he's got very good near vision, I would again not push him for a trifocal immediately. I would try to do a fusion or a hybrid lens, one eye with a trifocal and other eye with a fusion lens like Lucidis, so that the amount of glare and halo is reduced for him and he's got a blended vision. Complete range of near and intermediate vision.
Yeah, wonderful. I think that's what the carry home message I wanted for the audience, that whenever you're treating the moderate myopias for clear lens extraction, don't be overambitious. That's exactly what you said. And hyperopes are ideal candidates for these kind of lenses, but then again, the factor of angle kappa comes in. So you need to watch out there. One question to you, if a patient is having a dry eye, and you plan doing this surgery, what would you do? You treat the dry eye. Do you do a dry eye mapping again? When do you take the patient up again for that?
So routinely we do a pre-operative dry eye evaluation, mybogram. So mild to moderate cases, you can go ahead with implantation of these premium trifocal lenses. However, if they have moderate to severe, I wouldn't counsel them for these trifocal lenses, because post-operatively they are going to come repeatedly back to you, even with punctal plugs on table. I have tried on a couple of patients who had dry eye, put a punctal plug with trifocal implant, but the dry eye didn't really resolve, and they do have intolerable glare and halos post-operatively.
I think, again, Dr. Rishi was talking about the post-operative dry eye, and what I'm trying to highlight here is the importance of a pre-operative dry eye, and Pooja here is an expert in that. It's a must thing when you're trying to do these high-end lenses. I call them the light-bending IOLs. You know, they are the NTLs or the new technology lenses. You do not take them up without doing a dry eye mapping. And my last question is, since we have the armory of OCT, so many patients you see ERM, at what level will you decide you will be doing a trifocal or not?
So ERM is never a absolute contraindication for these trifocal or the ERV lenses. Again, it depends on the foveal contour. We grade the ERM type 1, type 2, and type 3. Type 2 and type 3 you have to be wary. Type 1, which is the early ERM, which doesn't have any anteroposterior traction, doesn't cause any tangential traction, you can go ahead. With the enhanced depth OCT nowadays, it's becoming much easier to quantify this type of ERM. So I would definitely say, please do get an OCT, SD OCT, or an enhanced depth OCT imaging in all these patients who are going for the trifocal implant.
I think that sums up my question. And I would just like to declare that probably the era of bifocal is gone. We either have the EDOFs or enhanced monofocals or the trifocals. So,
Thank you.
Thank you very much. The next speaker, we have Dr. Pooja with us. If you see that today every company is coming with an lenticle. So, you have so many companies with an lenticle because the trend is going to from a flap-less to either a surface ablation or a lenticle. We have Dr. Pooja Khamar, who has a high experience in this. So, Dr. Pooja, please.
Thank you, sir. And I would like to thank the CARE group and the AIOS for giving me this opportunity. So I'm going to switch a little bit gears from IOLs to refractive practice, a refractive suite. And now with Schwind, we have a combination of an excimer laser and a femto platform, which helps us to do both femto flaps and lenticules. So I think it's a complete refractive suite which we have. And I'm just going to be talking about and sharing our experience with the same. So we do know that the refractive incidence, like the incidence of myopia, hyperopia, and the refractive surgery is increasing by day. And every day, like if you see now that the incidence of femto lasers is around 6.3%, and people now are preferring more and more femto flap-based procedures and lenticular extraction-based procedures. So I think, a lot of people keep doing that we moved from ECCU to SICS to phaco. I think now also we have to move from PRKs to be moved to femto flaps and the lenticular extraction in future. So this is a beautiful slide because, again, no financial interest, but everything based on experience and the love for the machine. This is a very nice slide which shows the journey of the Schwind excimer lasers and now the femtosecond platform. It started with Keratom in 1992, and then you had the Schwind Amaris 1050 Hertz in 2013, and now you have the Schwind Atos, which is a femtosecond platform. So how does it help a refractive surgeon in the practice? First, I'm going to be talking about the Amaris, and then we'll go to the Atos. So Amaris platform provides us with 3 ablation profiles. Like it gives us an aberration-free, it gives you a corneal wavefront guided treatment, and gives you a Presby Max. So if you can see here, like if you have just a patient with myopia with no cylinder, like a spherical error and no cylinder, and if it's a relatively healthy cornea with not much of corneal aberrations, you can go ahead and do an aberration-free treatment. But if you want to do a topo-guided treatment, like there's a very good buzz about the topo-guided treatment for precision vision for post-refractive surgery, then you have the on Amaris, that topo-guided treatment which corrects the higher order aberrations is known as the corneal wavefront. So you do have your CW mode on the Amaris as well. And of course, the presbyopia patients also now are getting more and more accustomed to getting a refractive surgery done, so they also feel like having a spectacle-free correction. So then that's where we have the Presby Max. So trans-PRK is one of the most commonly performed procedure, and it gives beautiful results. As I said, you do have 2 options, AF and CW. How do you choose? If you have higher order aberrations on your cornea, you go ahead with CW, but if your corneal aberrations are on the lower side, then you can choose AF. But one of the beauty of trans-PRK in this platform is it's a one-step procedure, it's a 3D technology, and if you see here, I have highlighted the role of epithelial thickness. You can actually customize the epithelial thickness. If you do a PTK or any trans-PRK on any other machines, you just have to enter a 1-point epithelial thickness, let's say 50, 55, that corrects it for the entire zone. But it's not always the case. Usually, the epithelial thickness in the central and periphery is going to be different. So here you can, if you have an epithelial map, you can enter a customized epithelial thickness in this zone, and that's how you will have a better precision vision post-trans-PRK without any refractive surprises, be it a myopic or a hyperopic refractive surprise. So these are all the modes. You can choose a trans-PRK or a PRK, and based on higher order aberrations, you can choose whether you want to do a AF or a CW. One more place where it helps a lot is the CW mode is your irregular corneas. If you are dealing with a decentered ablation, or if you are dealing with a cornea which is irregular for any reason, then also you have an option of CW, and you can treat the aberrations on the same. And if you want to see what aberrations you have, you can just go to the manager, and it will give you a summary of the aberrations. Another beauty of this, which we love a lot, is you can customize the aberrations. Like if you feel like, okay, the coma is not very high and I don't want to treat the coma, I can just switch it off. And if you feel, no, I just want the coma is on the higher side and that is why the patient is unhappy, I can just treat the coma and switch off the other aberration. So that is how it helps me in truly customizing the procedure when it comes to the Schwind Amaris, which is the trans-PRK mode. And we have done a comparative study between the two trans-epithelial PRK platforms, and what we noted was that the healing was similar in both the eyes, but the quality of vision and the pain was much lesser with the Schwind Amaris platform compared to that of the other platform. Now, the second thing is keratoconus. Now, this is one of the platforms which helps a lot with true customization when it comes to keratoconus. It not only helps you to do a trans-PRK, but a TREC procedure also. So this is the planning, what you see the scan quality, the planning, you can choose the aberrations as I explained before, and then you can see how much it's treating. So why do you need trans-PRK? Because we know that keratoconic corneas are irregular, and the trans-PRK mode, it helps in flattening the cone area, and somehow it steepens the flatter area and makes it more regularized, so that the patient's not only the refractive error and the aberrations reduce, but the quality of vision is better and they accept the spectacles or contact lenses in a better way. So this is the planning in a similar way. You can choose the CW mode, you can choose a trans-PRK or a PRK, and then it gives you a summary. Now this is a very high ablation. In a keratoconic eye, you wouldn't want to treat anything beyond 45 microns, and if you see here, it's 82 microns. So again, as I said before, you can actually choose what aberrations to treat and not. So whichever aberrations are on the higher side, I can keep it on, and the rest I can keep it off, and that's how I can reduce the ablation depth. From 82, it has come down to 45, and that's how we can have more and more patients being treated. So these are just some of the examples. This is the pre-op map and the post-op map. You can see how regularized they are, and the refractive error and the aberrations have reduced, and the quality of vision has also gotten better. Now we keep getting questions like, you're doing a laser on a weaker eye. Usually you would want to avoid a laser on a weaker eye, and that's why you don't do a refractive surgery for keratoconus or formfrous keratoconus. So is it going to progress? So this is the data which we have published recently, which is a 10-year prospective outcome of laser-based cross-linking, and you can see here that all the patients are doing very well, and only one patient progressed in this 522 eyes, and one patient showed excessive flattening and one patient showed haze. So that means that it's not making your cornea weaker, and it's working quite effectively well. I know I have a little bit lesser time, so I'm just going to quickly go through the next procedure. If your corneal thicknesses are less than 450 microns, or if the ablation is on the higher side, can you still do a laser-based cross-linking? The answer is yes. There is a TREC procedure, again, a true customization. You can just ablate, you can just do a PTK in the cone area, the epithelial thickness plus 20 microns of your stromal tissue. You can measure the area of the cone on Cirrus or MS39, put the parameters on the PTK cam mode here, and this is what it ablates. You can see it's just in the area of cone, and then along with, once you have done the PTK here, you do a standard cross-linking, the accelerated protocol, and that is known as the TREC procedure. And here are some outcomes of pre-op to post-op. Works quite effectively well as your trans-PRK procedures. So if you don't have the space, or if your ablation is on the higher side for trans-PRK, which is the TCAT for cross-linking, you can go for a TREC procedure. Again, the quality of vision is much better, and spectacle acceptance and the contact lens acceptance is good. It also gives you an option of Press-B Max. Again, we love it a lot, and the best suited patients for Press-B Max are going to be hyperopic patients. You can do it for myopia also, but the best suited ones are the hyperopia, and the hybrid mode in them works very well. And why the hybrid mode? It's something similar to that of an enhanced monofocal. For the distance dominant eye, it's going to create a small depth of focus so that the near range vision is not lost, and then for the near, of course, it's going to correct and have an add of just minus 0.89. So that's why the Press-B Max is very important. Now, one of the very new tools is the Schwind ATOS. Now, Schwind ATOS is a femtosecond platform which helps you to create lenticular extraction and the flap creation. It's a low energy pulse. The advantage here is it's a low energy pulse, and it has an accurate laser focus, and it has a decreased stromal gas generation with tissue cuts which being more precise. But why is it better? Why we like that? Because It has an intelligent eye tracking and a cyclotorsion compensation. So I'll come to that in the next slide. If you have a Cirrus, if you have an MS39, if you have a Pyramis, you can link that up with your ATOS machines, and it's going to help you eye track and compensate for your cyclotorsion. So the astigmatism corrections are much more precise here. And of course, the lenticular geometry is also very good, which gives you a good outcome post-surgery. So as mentioned, you can use any of these tools. Dr. Kishore is here, so he's more expert in this, but I'm just going to try to do justice for it. While you're doing a treatment, if you're in the green zone, that means you are very well centered, but if you're in the yellow zone, that means it's not well centered and you need to come here. That's how the scans from your Schwind or MS39 is going to help you. And I'll just take one more minute. You can do flaps or lenticules. This is the planning station. You can customize the energies, like what energies you like. You can customize your spot size, your spot separation. And this is what it is. Anything between 75 to 135. We have had a very good experience with 85 nanojoules with a spot distance of 4 microns and a track distance of 3 microns. And day one, we get quite good results. This is the slit lamp pictures. And you can see from this, we corrected a cylinder of 1.75, and this is the day one result. And just will quickly show the procedure. This is how it is. The docking is, you see that you will feel it's a little decentered, but it's just the camera effect. The cameras are located at 45 degrees. That's why you feel it's decentered, but because of the tracking from the MS39 or Cirrus, it's quite well centered. And once yes, you can see it here how centered it is. And then you just go ahead, find the anterior and the posterior planes, and go ahead and dissect it off. We keep getting questions whether they do have a rescue mission or not. Yes, they do have a rescue mission. If you have a suction loss at any step, like for example, after the posterior plane is created, you can do a cap cut. And if you have a suction loss after the cap is created, you have the option of incision only, where you can go ahead and redo the procedure and still go ahead with a lenticular based procedure. Thank you.
Excellent presentation, Pooja, as usual. First of all, I'll talk about the technology. I think even I'm a user of the Schwind technology, and I still feel, at least my personal opinion, this is one of the most customizable LASIK machines, at least I've used. You can actually get into the system, make the machine do whatever you want. You can fool the machine, and the machine will not fool you. It will not let you down. If you're doing something wrong, the machine will warn you, but still you can play around. And I think I must compliment NN, Pooja, and Rohit. I started doing Trek after I attended your sessions. So it's a big boon for our keratoconus patients. And I think with this machine, you can play around the stuff like crazy. And my experience of PRK, or the surface, is amazing. The recovery, Rajesh probably also has used this machine.
No.
The touchless procedure, or the PRK, the healing is very fast, probably because of a very smooth edge design and the Mundelein formula of firing patterns. It's a very smooth surface. The epithelium grows very fast. Third day post-op, 80% of patients are without contact lens. And the healing is also very painless as compared to the other systems. So that would be my summary on that, sir.
Yes, what Pooja is saying, because I use this machine almost since last about 14 years now. When SPT Smart Pulse technology came into this, that was really in a boom for that's what I said, probably the future is going to be where you have a surface ablation or a lenticular, and a flap is probably going to be a little less thing. And what Dr. Kamal says is really, we remove the lens on the next day, and third day the patient does not have any pain. And even the pain score, if you see in an SPT, is much less than the other. They come very late as compared to an SPT, but then still the pain score is very low. Thank you, Pooja.
Thank you, sir.
And,
thank you.
Now next we invite Dr. German Bianchi, who is going to talk to us for his experience of 7 years with an IPCL. When the IPCL was introduced, the first Indian phakic IOL, I think that changed the whole of the scenario in our Indian market, that how the IPCL is being used today.
Okay, good morning. Thank you very much for your invitation. I very proud to be here in front of you. Today I will talk about my experience, my 7+ years about IPCL. I start with IPCL 7 years ago, and today this is the resume of my talk. This is the resume of my experience about IPCL. I started with the model V1, after that with the toric version and V2, and I have some presentations around the world because when I start, I didn't found any publication, and this was my first publication about the model V2. With just 6 months of follow-up, I found very safe IOL. The endothelium, the CCT was really stable after 6 months, the VOL2 and the IOP2. And also it was very secure for the refraction too, with very good results. And also I realized that the volt not was just a number. The volt is a dynamic parameter. And I found in different light conditions with photopic and exotopic with different intensity of light that the shifting of the volt is slightly lower than 100 micron, and it's different another IOLs like ICL or the biotech. And well, it was presented like a peer review. Also, this is another study that I did, the presbyopia management with the diffractive phakic posterior chamber IOL. This is the first IOL that work together with the crystalline lens. It's a diffractive IOL that work together with the residual accommodation of the IOL. And this is the focus curve. And also you can find that when I did this study, I also present this nomogram because I didn't know at that moment how to correct the presbyopia in this patient. And I realized that it's not dependent only the age of the patient, dependent also the myopia of this patient. And in the majority of my patients, I did the blend. In the dominant eye, I put the most addition that the patient tolerates, and in the non-dominant eye, I put a little bit more addition. And when the patient don't tolerate, I put the same, but the most addition. Could you put the sound, please? This is a lady after 48 hours of the second eye that I did the surgery. Well, they said in this real, believe me, that she said that she don't feel halos, she don't feel anything, and she can have very good far and near vision. You can put sound, please? No. Okay. It doesn't matter. And this is my own technique that I use to introduce the IOL, the hydroinjection on phakic IOL. I also published this technique. And for me, it's a very good technique because I don't find any peak of IOP after surgery. I use this irrigation cannula with the 20 gauge, and after that I did the 2.8 millimeters main incision, and I inject the lens under irrigation. All of my patients have this kind of surgery. For me, my technique is very safe, and I don't have also cataract, and I never broke the anterior capsula with this way to do the surgery. This is also the real time of this surgery. Also, I realized the cyst prevalence. I realized that there is a lot of cysts in my population, and I found this cyst, and the prevalence is near of 50% of my patients. And also, 82% of my patients were bilateral with the cyst in both eyes. Also, I present in ARVO the last year, and I found that the very real bolt between 400 and 600, these patients don't have cyst. The rest of the patients have more cyst and are out of this very good bolt. And also I realized that the patient that has more than 750 have cyst in sulcus. Also, we know that there are differences between ICL and IPCL, and this is a new study that I made and realized that with 5 years follow-up, I realized that the vault was very stable in all of these patients, just reduced a little bit when the vault is more than 750. And also, this study is about the endothelial cell density, and it's very stable after 5 years, and also the intraocular pressure. Also, I did this surgery in some extreme case, like this, with minus 31 and with the cylinder. You can see here that the surgery and the thickness in the periphery of the optic is thicker than the other lens, and you must take care in these cases because you need anterior chamber and the angle between the iris and the cornea a little bit more than the other patient. And it was with very good result, very secure. And in this case, we can see the central vault and also the peripheral vault is very important too. And well, this is the same picture. And also I did the surgery in some emmetropic patients. And this is not the normal, but sometimes comes people with 50 years, 45 years with emmetropia, and I used to put this IPCL to correct the presbyopia with very good result too. This is with sun. You can see the subtitle there, but this is a man with 50-year-old, the IOL with plus 0.5. And in the dominant eye, I use the addition of plus 2. And in the non-dominant eye, I put the addition of plus 3. I asked about if he can drive at night, and he said that they don't have any problem about that. And also he improved the visual acuity for far vision, more than 20/20, and for near vision, Jaeger 1. And I think it's an option, but it's not for every patient. We need to know how is the angle and how is the anterior chamber, and in a metropic patient is not always a good patient for that surgery. But also we need to learn about our complications. Every doctor that makes surgery has some complication, but I have just 3% of my patients. The most common complication was the rotation of the toric IOL, and I realized that all of these patients have cyst in sulcus. This was, for me, one of the reasons because of that. This is the lesson learned for this complication. And also low vault. Low vault is not just a number like I said before, because it's an adynamic vault, because depends on the light condition. And some patients I need to take, and this is another complication, the high vault. It's happened. Sometimes the capture of the pupil could be you need to exchange in this patient. And also sometimes I found cataract. The 3 patients that I have cataract was the model V1 because of the vacuum, because this lens don't have the central hole. But the new model has the central hole, and I don't have any complication with cataract in my patients. Not every patient that has cataract, you can take out the IOL, because we need the central hole is very important because the viability of the epithelium of the anterior crystalline lens is very important for the diffusion of the aqueous humor. Cataract is not caused by the lens material, but we need the circulation of the humor aquosus in these places. And, well, this is the complication, 10 eyes, 3 eyes with rotation, 4 eyes with low vault, 3 eyes with cataract. And the low vault is important, but I have patients with low vault and without cataract with the model V2. And, well, we need all of this information, and we need to know that it's very easy to remove the IOL. The model V2 I take from with the cannula from the hole of the optic outside, and it's very easy to take out in that way. And with 1 or 2 McPherson you can take out. In this case I take with 2, and it's very easy to remove. And in the same procedure, I inject underwater the IOL. And this is another video from the model V1, just this similar surgery, but in this case, this model don't have the hole in the optic, and I take out with the forceps from the optic, like you see here, and with, in this case, with 1 McPherson. Well, the important thing is that from all of my patients, I just have 3% of complication. This is very important, the pre-op study and the post-op follow-up. I think that the UVM is one of the most important studies, that because we need to know how is the anatomy of the sulcus. That is the place that we need to put the IOL. 7 years ago, I trusted the company and the IPCL, but nowadays I have evidence-based medicine to prove it that the IPCL is very good IOL for correct high myopias. This is the congress that I am a director in Cordoba. The name is Ophthalmo Cordoba. You can take a picture of the code, and you can join us in this congress by streaming. Thank you very much for the invitation.
Thank you. Thank you, Dr. Bianchi. Very nice presentation and very nice details of the procedure and the complications. So that's a highlight of it. So you know that what complication you make it and how to rectify those complications. The one thing that you showed of that diffractic IOL that you put for you said the difference was in a 0.5.
Sorry.
Difference of a 0.5 diopter in 2 eyes?
When I used the diffractive IOL, yes, I used to put the difference between the dominant eye and the non-dominant eye. I used to do that, and I have very good result in my patient. I used to put the most addition that the patient tolerate in the dominant eye, and I put a little bit more in the non-dominant eye, plus 0.5 or plus 1. I have a very good result with that, and sometimes I use the same addition in both eyes when the patient don't tolerate the addition.
Yeah, thank you very much. As we are running short time, so we are just going to make a little change in the. Dr. Kamal has written one instruction course, so I request Dr. Rajesh Vogla to come after him. Dr. Kamal Kapoor, he doesn't need an introduction. He is going to talk to us the future of cataract surgery, how the trend is changing. What he said is bifocals are probably going to be obsolete. Now you have either an EDOF or an EDOF monofocals. So he is going to talk on magnificent EDOF lens, which is going to be in a future of the cataract surgery where monofocals are going to be obsolete. Dr. Kamal Kapoor.
A very, very good afternoon. I think, first of all, I must apologize to the speakers whose turn I'm jumping. I've got an IC coming up. So I think a wonderful session. I just add a few points to Dr. Jermaine by the time they start with my presentation. Hydroinsertion of the phakic IOL is an excellent idea. Lesser rotation, lesser change of vault in the first 1 week. But yes, sometimes if the loading is not perfect, it can tilt and twist and cause cataracts. And another big plus point of this is that you have a stable vault. So your planning of the second eye can be very fast. If you put a viscoelastic, you can have a variation of the vault. So having said that, I'll be coming to the topic of EDOFs. This is probably the new kid on the block. They're probably not so new anymore. A lot of us are using these lenses. But I actually feel the era of monofocal lenses probably is over. The era of bifocal is getting over now. See, the iatrogenic presbyopia created by the surgeon, the holy grail has been the presbyopic correction. And are the EDOFs or the enhanced monofocals the holy grail? Because gone are those days when you need, all the patients are so demanding, they want more near vision. I have no financial disclosures for this particular presentation. So is this the missing link, the enhanced monofocals or the EDOFs? I'll go very fast because I will rush for my IC. So actually this is a huge presentation, but I'll be just talking about these few points. When we talk about the EDOFs or the enhanced monofocals, we play with the spherical aberrations, we play with the chromatic aberrations, and we also play with the refraction diffraction. What is the role of the pupil size, especially when you're talking about enhanced monofocals and EDOFs, corneal surface disorders, and the patient selection? So major categories you'll see of all presbyopic correcting lenses would be the multifocals, which would be diffractive, refractive, enhanced monofocals, the EDOFs, the pinhole lenses, and the accommodative lenses like crystal lens. Principles or mechanism of action would be a diffraction, refraction, or the pinhole mechanism. The principles, again, I will not go into the details. Actually, an EDOF is defined as a lens which gives you a continuous zone of focus with a very, very slight loss of defocus or a blurring zone. So these lenses will subserve majority of your day-to-day functions provided you have a right patient selection. You don't have a bad cornea, your astigmatism is well within control, your biometry is totally online, you will get excellent results. So this actually stretches your focal point onto the retina. Unlike the multifocal lens will give you zones of flare, zones of blur, zones of clear, zones of blur. So the multifocal patient can give you or complain to you of a waxy, washed out image. Now this is what a monofocal lens would probably appear as, a single point crisp photo image. A diffractive bifocal will have two sets of focus with a zone of blur in between. And a trifocal will have three sets of focus with a zone of blur in between. Now these sets of focus are according to the distance. Now let me tell you, the patient's height is also a very, very important feature when you're doing these presbyopic correcting lenses. This lesson I learned long, long ago when I ventured into the presbyopic lenses. Tall patients will tend to be more happy. They have a longer arc length of the arm, so they are very happy. So very good patients are tall patients. I am 6'1½", I would be an ideal patient for EDOF because I'm 55, I don't need reading glasses. I'm a hypermetrope, I don't need reading glasses. I still can just move a little bit, which is still very comfortable for me and do the work. But a shorter patient will need a near eye. So you need to decide, seeing the physique of the patient also. I see so many audience smiling here, probably I've given them something new. Everybody is nodding their head. So when you have a shorter patient, you need to play with the micro mono, or you need to probably go in for a trifocal. In an EDOF, you have a stretched zone of focus, which is not a crisp, discrete zone of focus. There is no zone of blur in between, a slight elongated zone of focus. Now let's understand the spherical aberrations first. We all know a positive spherical aberration is when a peripheral rays through a lens are meeting before the focal point. And the negative spherical aberration is when they're meeting behind. What an enhanced monofocal lens like a magnificent or an Eyehance does is it just plays on the negative spherical aberration. It just gives you a longer zone. So then the question is, why not play it more? Why not give more negative spherical aberration and get a better depth? We'll see why we can't do that. There is a limit to that. If you start playing with it, the peripheral image, when the pupil dilates, starts getting distorted. So there is a very small zone which you can play with, probably a near of anything between 0.75 to 1.5, 1.75. You go beyond that, you'll have peripheral issues in your zone of vision. So the last slide you see is something which would be playing on the negative spherical aberration. Now add on it the diffractive nature, like Symphony or other lenses, where you will have another add for near work. Now what would happen if you overplay the negative spherical aberration? The peripheral image or the dilated pupil will get distorted. So you have a safe zone of playing maybe 1, 1.5, 1.75, and you can get away with it. This is again a classical example. Now this is what would look like, taking a photograph through a highly spherical aberrated fisheye lens. Now enhanced monofocal lens, I have a huge experience with this magnificent lens. Probably more than 4,000 lenses implanted, very, very happy patients. And over time, I think I was one of the first ones to realize that it really does well if you do the non-dominant eye first. When you're playing especially for both eyes, do the non-dominant eye first. And I correct the first myopia on my optical biometer, which is anything less than 0.65. The first myopia is my target, and the second eye is emmetropic. These patients do phenomenally well. We'll share something with that. The American Academy of Ophthalmology describes a EDOF lens as any lens which does not take away 6/9 or better lens, and yet in 50% of the patient gives you an intermediate vision of N9. Now, the comparison of the logMAR scale, as this previous slide says, that it has to be 0.2 logMAR. So 0.2 logMAR would be approximately, if you go here, if you keep moving on there, it's 6.9.5, 6/9.5, which means the patient should be unaided 6/7.5, and for near N9. If in more than 50% of the implanted patients, you are achieving that, you can be classified as an EDOF. This is a very, very loose definition, but it's being tightened now. Now, this is the last definition which I talked about. So just describes what I just told you. An EDOF will give you a zone of clarity which is much broader than a monofocal lens. A monofocal lens, you will have a crystal clear vision at a distance beyond or 6 meters and beyond infinity. But in EDOF, you will have a far clearer vision even in the nearer zone. A monofocal will start behaving this as the lower image as the object starts coming nearer. But the EDOF will continue to play with a slight amount of edge blur and still make you do your daily work. Now, this is a huge chart. I'll just talk about, we'll talk about EDOF and monofocal enhanced EDOFs. Brought two categories. A hybrid would be any lens which has spherical aberration built in with diffraction or refraction. Or a true EDOF would be only lens which is playing only on your spherical aberrations and chromatic aberrations. These are various lenses. I will not go into that. Vivity is a classical example of a true EDOF, but it is based on a beam scatter or a beam focus technology. I've had a lot of experience with Vivity. Vivity is an excellent lens, but can give you waxy vision in some patients. When the pupil size is not under control, I've used a lot of these lenses, isopure lenses also. So I have a large set of experience with all the lenses. So in my armory, in my practice, this lens magnification fits beautifully well. It's cost effective. Most of the patients can afford it, and majority of my patients, I'll share my okay, this is something interesting. The area under the graph of MTF will decide what is the amount of light energy the patient is getting and what is the amount of clarity in the zone of depth he can work with. So in the EDOFs, you have a maximum number of area under the EDOF graph, the MTF graph. So you have a long range of clarity of vision with least amount of loss of vision. Unlike a trifocal where you have 3 bumps, the patient will see clear at one point, blurred, see clear, blurred. So there's a loss of energy in between. In an EDOF is a continuous decrement, so it's a continuous zone of vision with no intervening zones of vision. The Technis High-Ends, which is probably the next comparable lens to the magnificent, boasts of a probable, the literature says 1.5 diopters of near ad in the central zone, but if you actually get into the optical bench studies, a lot of them say it's anything between 0.89 to 1.12. So the average is 1 diopter. So you're actually seeing a 1 diopter of a near ad in these lenses. Whereas the magnificent in a radius of 1.5 millimeter is actually going to give you 1.75 diopters equivalent of a myopia, which is a fantastic amount of depth. Now, I will share our experience in a set of group of patients we did. We could see patients seeing N6 bilaterally with blended vision. 68% patients in my clinic are N6. And 6/6, both eyes open. That's phenomenal. And when I shared this data with the company, they say it's not possible. We didn't make this lens to do this. And that's when I shared with Sanjay and the team that that's what I'm doing. I'm playing around with the bilateral blending. So this is how the lens is actually designed. The central part will have a higher dioptric power than the periphery. So in a dilated pupil or any pupil more than 3 millimeter, you will have the complete power of the distance. When the pupil constricts, as you bring the object nearer, the central part kicks in and it starts. I'll just jump these slides. So this is the 4,000, more than 4,000 IOLs done. So case selection is important. You need to tell the patient, the language we use is 80% of your daily life, you will not require glasses for near vision at all. That's the opening sentence. So the patient is already mentally programmed. And we tell them, if you want to read a medicine label, you want to thread a needle, you will need glasses. Once you plan and program the patient for that, and if he gets more than that, he's more than happy. So these enhanced monofocals like magnificent are more forgiving, no halos, no glare, no dysphotopsias, far more better range of patients, even in borderline surface disorders, borderline ERMs, borderline maculopathies, glaucoma patients, you can use these lenses, so your range is much wider. And one interesting point is, if you used a monofocal in one eye, you can jolly well put a magnificent in the other eye. So 30% of my practice is in the second eye, I'm putting a magnificent lens where I put a monofocal lens. So I guess I'll skip it. Thanks a lot.
Thank you, Dr. Kamal Kapoor. It's as you said that, I mean, probably the monofocals are going to be obsolete when you have an advanced monofocals in our practice, like how trifocals have taken over the bifocals. Next, I request Dr. Rajesh Fogler.
Yeah, sure.
Please.
See, the magnificent comes in a toric also. 0.75, and I still do a steeper axis and I do an OCCI. Even at 0.75, I do an OCCI. I need to see whether I have an against the rule or with the rule astigmatism. I prefer doing an OCCI even if it's 0.68 because it gives me a better depth. A lot of times the text will tell you that 0.75 and below you can do away with it. But in case you are comfortable doing OCCIs, go ahead. In case the incision site permits you, a lot of times you'll have the nasal part coming in, you cannot do that. But in case you can, try and reduce the astigmatism as much as possible and you will have very happy patients.
In this, the company doesn't really tell us how their lenses work. They're not.
I told you.
No, they haven't revealed it. So how do you find it different from my hands? So I
also find the results with magnificent to be better. So,
See,
really what is the difference?
Yeah, I just shared that. The company, the Technis says that they have a NIRAD in central 2 millimeter. The literature and optical bench studies, if you go into it, say it's anything between 0.92 and 1.12. So the average is 1 diopter in 2 millimeters. Here, they are saying that in 3 millimeters, they are giving you 1.75. So it's a little wider zone. And so the smoothing is very gradual. So the tendency for you to have the edge blur is lesser because it's a larger zone, so they have a long area to taper off at the periphery. If you have a shorter zone and you taper suddenly. So I think that's the trick they have. They have a lot of tricks up their sleeve, even in their trifocals and tridiffs. The amount of the gating phenomenon they do is amazing how they managed it.
Kamal, do you have any experience with AdTech comfort lenses? AdTech.
AdTech, yes, I have. In fact, I said most of these EDOFs I've used them and moved on. AdTech is a very good lens. In my hands, I feel it has folds. Anybody who's used AdTech here, raise your hands. Winters, you will have folds in the center of the lens for first 3-4 days also. Some of the times it will disappear. Any lens more than 22.5 diopters, I can show you 20-30 videos which I showed the company. So first they thought it was an injector issue. They changed the injector with me and I was working closely with them. I think it's a material issue. Most of the lenses will lose these folds as the lens opens inside. You'll see 3 classical folds, the longest in the center and 2 smalls at the side. You wait, you see the first day post-op, they don't go. Most of them go 3rd, 4th day, but some of them, they don't. So these are material cracks. These are material cracks. They may not bother the patient, but as a surgeon in retroillumination, they bother you. It's like Acrosoft. Glistenings don't bother the patient, but they bother the surgeon. It's something like that.
Thank you.
Thank you. Dr. Rajesh Fogla, he doesn't need any introduction. He is going to talk to us as a new technology. It's an Zimmer Z8, which you can do on a cataract as well as on a cornea. Dr. Rajesh.
Well, thank you. I think I'll rush through the presentation because the session is till 12:15 and we have 3 more speakers to give the talk. I'll talk about my experience of the Z8. We have been using the Z6 for the past 9 years and we acquired the Zimmer Z8 last year. It's a truly versatile, portable femtosecond laser. Does a wide variety of procedures. How is it different from the other lasers? It has a articulated handpiece which comes very close to the eye. So you don't need to bring the patient to the laser machine, but the arm piece, the handpiece, you can dock it on the eye. It works on a low energy pulse which is overlapping and very high frequency, and thereby it ensures that there is minimal tissue damage. And also integrated OCT also helps us during the procedure, that once we have applied the handpiece on the eye, we can do a corneal OCT to look at and adjust the treatment that we are performing. You can do refractive surgery like LASIK. You can do the clear procedure, which is the lenticle extraction. You can make the stromal pockets. You can do lamellar keratoplasty, penetrating keratoplasty. You can do intracorneal rings. There's a special software for DALK, and you can also do the cataract surgery, the femtosecond cataract surgery. Now, we have been using the LASIK flap for several years now, and the best part is it is very, very reproducible. We use minimum thickness of about 100 microns and gives a perfect flap every time with a very smooth interface. And you can customize the edges to various configurations to ensure that you get perfect fit of the flap. The recently introduced lenticle extraction, the clear procedure, you can see that it works equally well as compared to the other existing laser systems in the market. You do the 6.57 millimeter zone of treatment, and finding the anterior and posterior plane is very easy. And once you optimize the laser energy levels, you find that there is minimal resistance to the dissection, both for the anterior and posterior plane, and you can very easily remove the lenticle from the eye. That's how the cornea looks the day one after the clear procedure. And if you look on retroillumination, the interface looks pretty smooth. That's on the OCT thickness maps. You can see very well-centered treatment. On the cross-section, also very smooth interface. And if you look at the day one topography difference map, you can see very well-centered treatment. And on the AR, you can see the values are almost zero. That's our initial treatment when we did. Even the learning curve is very smooth. If you're starting off with a nomogram, still a majority of your patients are achieving 6.6 with minimal residual refractive error. In terms of doing a DALK procedure or a PKP, it's very good. You can customize the edge incision. You can make mushroom, top hat, zigzag configuration, and you can do the big bubble DALK. You can, and the best part is that once you have, you can, even the donor can be customized to the shape that you want. You can see there, it's a top head configuration, so it fits very well. The advantage is that it gives you minimal astigmatism and a faster visual recovery following the surgery. We have been using the rings and the stromal segments using the femtosecond laser. The best part is you can customize each segment. You don't need a circular, similar opening. You can make a different pocket for an inferior segment and a different pocket for a width pocket for a superior segment. And it has all the various parameters for the Intacs, the Kera rings, the Ferrara rings, and you can even manually customize the inner and outer diameter and the width of the pocket that you make. For introducing the stromal segment, I use a metal template, a ring, onto which with the stromal segment is sutured, and then when you pull out the metal ring, the stromal segment quickly goes into the pocket, make it very easy to implant the same. We have also been doing stromal lenticule insertion for keratoconus, where we cross-link a lenticule that's also prepared with the femtosecond laser. Then you make a pocket, and then you can pull in a lenticule into the pocket, and thereby it increases the central corneal thickness, and thereby later on you can go ahead and do a topo-guided PRK to achieve a much smoother corneal contour. In terms of doing the femtosecond cataract, you can keep the laser machine in the OR next to your microscope, so you don't need to shift the patient between the laser and the microscope. It can be without moving the patient. You can make your clear corneal incision side ports, which you can see in this case, despite the arcus, it made very nice openings. I've also done an arcuate keratotomy to treat some of the cylindrical power. You get a free floating rhexis. You can make 4 to 6, 8 segments with ring segments as well. And once you do that, it significantly reduces the overall phacoemulsification power delivery. The segments can be broken, and you can do that, ensuring a good central rhexis and good centration of the IOL as well. I'm just running through the videos because of lack of time. I have to be in another hall for an instruction course. And so basically the Z8 femtosecond laser, it's the only portable femtosecond laser with multiple clinical applications ranging from cataract, refractive, and cornea. You can use it for vanishing keratoconus. You can use it for even surface reconstruction procedures. They have shown videos of being used in pterygium surgery to prepare the conjunctival flap, and also in limbal transplantation, both to harvest the limbal segments and for transplanting them into the cornea. So thank you for a patient hearing.
Thank you, Dr. Rajesh, for finishing in time, so we can give a time to the other. This is what we say is a portability of the laser. So you can just take it from an LASIK room to the cataract near the microscope, and then again take it to the LASIK. Next, we invite Dr. Practiti, who talks about an ageless phase matching technology to achieve true panfocality, which is in a natural lens. Dr. Prashad, everyone knows about him. He knows the physics, and he knows the aberrations where we learn from him. Dr. Prashad.
Hi, good afternoon, everyone. So I'll be speaking about the edgeless phase matching technology, which is the new kid on the block. If we consider the optics of IOLs in presbyopia correction, then this is something which is drastically different from what we know, which is either a refractive or a diffractive optics. So I'll start my talk by introducing it in this way. My top 3 concerns as a clinician while using a presbyopia correcting IOL is, number 1, what are the visual side effects of this lens? So what is the extent of starburst, glare, halos, waxy vision, ring shadows, ghosting at night time? What is the extent that the patient is going to experience this? What is going to be the range of vision? So reliably, how much spectacle independence am I going to give to the patient? And third is the compromised quality of vision. Distance vision is the most important factor for patient satisfaction after cataract surgery. And if that is compromised, then the patient is usually unhappy. So right now we are stuck between the 2 choices. Either there is an EDOF lens or a trifocal lens. In an EDOF lens, we have the advantage that it has less symptoms of night driving, and glare, halos, etc. are low. It does give spectacle independence, but only to a limited range, and it has minimal loss of contrast. So clearly it is the choice if we are looking at a lens which has good tolerance. But if we look at a trifocal lens, it has excellent range of vision and spectacle independence is truly there. But the problem is in the quality of vision and is in the side effects. So the question arises, why do trifocal or multifocal IOLs have these side effects, which is pushing everyone towards EDOFs? So the answer lies in this patent that was filed in 1998, which shows that the steps of diffractive IOLs are the cause of side effects. So what this patent says is that light incident from an off-axis point, which is not aligned with the principal axis, when light is coming at an angle, it is incident on these steps and scatters at these steps. This scattering increases with increasing angle and increases with increasing step height. And to address this problem, what we can do is we can align the light parallel to these steps. Or we can coat these edges with optically opaque material to do away with the side effects. And this has been tried multiple times since the very first apodized diffractive lens, which actually reduced step heights as you go to the periphery to ameliorate the perceived glare or halo or rings around a distant discrete light source. This was around 14-15 years back. Then there has been attempts to reduce the number of steps. And then there have been attempts to reduce the step heights also. So the question is, what was the need for these steps? The need for these steps is to basically match the phase of light to baseline, which is essential for constructive interference or for diffractive optics to work in simple terms. But the side effect is obviously this unaccounted light loss. Now the question is, why do we not discuss this light loss? We have been using lenses for so long. No company has ever given us a data about the unaccounted light loss that is happening. The reason is that the data comes from an optical bench where the light comes parallel to these steps. So you never know exactly how much light loss will happen at these steps in real life when it is in a patient's eye. Because in real life, the situation is like this. Light is going to come in a slanting way and going to undergo multiple optical phenomena at these edges, and these phenomena are going to be unaccounted. So this light is not reaching any useful focus. Naturo is one lens where we have 0 steps. So there is absolutely no steps, but the phase matching is still there. So that is why it is called the edgeless phase matching technology, where a negative kinoform phase matching has been done. Now what does this mean? If you look at the base curve, which is the top, and the second conventional kinoform profile, and you add both of them, you fuse both of them, you will get a conventional bifocal diffractive lens. If you use a negative kinoform with the base curve, you would get a lens which would have a base power and a minus power as a second focus. So it would be like a 20 diopter lens with a negative add of 2. So 20 and 18. Now if you match both of them together, you would get something which is called the LMAX profile, where you can eliminate all the edges of the diffractive optics. And I was not convinced by what was told to me. So I have actually gone ahead and did multiple studies with independent evaluators, including the University of Valencia in Spain and in Belgium. And I actually got the optical path distance of this lens analyzed and realized that it actually does diffraction and does work. So how does the LMAX profile work? If you look at a conventional profile, then all of the steep edges of the blazed sawtooth profile, diffractive profile, are actually causing light loss. So if you analyze the whole surface and you stretch it out, then there are circles of surface area where the light, if falling, is actually going waste. In the LMAX profile, there is no such area of light loss. So basically, the complete surface of the optical element is throwing light to a useful focus. And that is why there is no wastage of incident light and there is no ghosting or ring shadows. So this is the basic difference between the conventional diffractive optics or the trifocals versus the edgeless phase matching technology. Now, another thing that comes with diffractive optics inherently is the ability to actually make light distribute to different foci independent of the pupil. So you don't actually have to be dependent on the size of the pupil aperture to actually see the light efficiency. And this has been worked or tweaked in this live vision technology, which was awarded at the ASCRS in 2020, so that the lens actually slightly skews the light distribution in favor of the kind of work that the eye is doing at the time. So basically, we analyzed, and here some of input goes from our center and our study, where we analyzed the light conditions in different daily activities and analyzed the mesopic pupil size for the Indian population in those lighting conditions. And the light actually goes in such a way that if you go in the outdoor daylight in a small pupil, the lens has actually very close in performance to a monofocal lens. So the distance vision quality is not waxy at all. In the indoor ambient light, you get the 3 foci and a large area under the curve, as Dr. Kamal was saying. The wastage of light here is gone. So the advantage in EDOF used to be that you don't have any wastage of light. That advantage you get here with a complete range of vision. So it's a very disruptive concept. And if we look at the surface profiles compared to all the other trifocal lenses, you see that the profile is completely different, wherein the complete elimination of a steep edge is there. So there is absolutely no wastage, which leads to more light going to every focus. So the light loss from these steps is gone, and that adds to more clarity at each focus.
Perfect.
We have done a study of around more than 500 eyes, and it shows that we get great range of vision. If we look from 100 centimeters onwards, then we see that the light is actually 6.6 or better at most of the foci, with no disturbing glare or halos. Ultimately, our chair time reduces, and we use this lens most often in our CLE patients. Thank you.
Thank you, Dr. Bakshar. We have I just will take 5 minutes more. I invite Dr. Ayan Mohanta to talk his experience with the triphobic and triphobic toric IOLs. Can you just finish it fast? So we have to give a session, halt to the other next session.
So, thank you, AIOC, for giving me this opportunity. I will quickly run through my slides with my experience with triphobic and triphobic toric IOLs. So I'm a consultant with the Disha Eye Hospitals. So the trifocal, this is the only trifocal that offers a full range of vision correction, provides far, near, and intermediate vision, balanced distribution of light, provide better contrast sensitivity, spherical aberration correction to essentially zero, a pupil-independent trifocal lens, high quality of vision in all light conditions. It's a synchronized cast-boarded lens. So this is the geometry of the lens. It's a 6 millimeter optic with a overall 13 millimeter size and 4 millimeter diffractive zone. And the toric marks are aligned with the haptic optic junction. This is the diffractive surface profile. It's a biconvex lens with a modified refractive aspheric optic. The material is hydrophobic and it is a C-loop haptic. The A constant is 119 with a refractive index of 1.53. Haptic angulation is 0, and it's available from 0 to 35 diopters with 0.5 increments of optical power. It has a 4 millimeter diffractive anterior surface, as I've already told. The delivery system is disposable. So it has a unique asymmetric diffractive zone with increasing steps angulations and decreasing step height. So the light distribution in photopic condition is 52% for far and 18% intermediate and 30% near. So more or less it's constant in all kinds of pupil sizes. So trifocal IOL is pupil independent for far, near, and intermediate, and light is distributed to intermediate, near, and distant focal points, retaining high quality near and intermediate vision in mesopic and scotopic conditions. So as far as scattering and halo of light are concerned, all multifocal IOLs have potential for creating halos, as we are listening for so long. And halos and glares are created by the amount of light that is lost. IOL design attribute plays a significant role for minimizing halos and glares. And trifocal superior patented optical design minimize significant loss of light, resulting in very low incidence of halos and glares. So it has a decreasing step height and increasing angulation from center to edge, which ensures excellent light distribution for both focus points, near and far, with minimal chance of halos and scattering of light in all light conditions. So this is the defocus curve of triphobic IOL. You can see there are 3 humps, one for the distance, and for the intermediate it's around 1.5 to 1.8, and there is another hump at around 3.5. So if we look at the contrast sensitivity and the energy scan for trifocal is in 50, 30, 20 light distribution for far, near, and intermediate.
Excuse me, sir. We have to hand over the session to the other. So
please very fast.
Slides if possible.
So, and coming to my experience, this is a small video on the lens. So it's a disposable injector, as I already told. The implantation is fairly easy, and till now I didn't have any problem with the injector system. So this was my personal study. It's very small. It's 49 patients with age distribution of 50 to 80 years, with female ranging from female patients 45 and male patients 4. And these are the toric and non-toric lenses 42 and 7. This was the pre-op vision distribution. And most of the patients had very good 6/6 vision with 10/6. And also in the toric, we have got this is a pre-op vision, and again there was a 6/6 vision in all the patients of triphobic toric. And one patient had a photic phenomenon, one female patient. And thank you very much.
Thank you, Dr. Mohanta, for finishing in time. So we conclude this session with a comment that, we have an Indian company who has expanded its horizons, and then we have speakers from outside, and then we have a technology which is matching to the world standards now. Thank you very much.
Thank you, everyone.